I'm going to be talking about cell therapy for chronic ischemic heart disease from concept to clinic. So as we've been discussing, stem cells are self-renewing clonogenic multipotent cells capable of contributing to organ regeneration. The stem cells found in adult tissues serve as a new potential therapeutic option for regeneration and repair of structurally and functionally damaged organs, and in particular the heart, which we're discussing today. So what we've been studying mostly in our institute is our mesenchymal stem cells. Mesenchymal stem cells were initially identified in bone marrow, but have since been identified in multiple other tissues, including adipose tissue. They are defined, generally defined as plastic adherent under standard culture conditions. They're positive for expression of CD105, CD73, CD90, among other markers. And they have absent expression of hematopoietic stem cell surface markers, so, including CD34, CD45, CD11, CD19, and HLA-DR. Under specific cell culture conditions, mesenchymal stem cells differentiate into osteocytes, chondrocytes, and adipocytes in vitro. And there's a lot of literature showing that mesenchymal stem cells participate in wound healing. They have immunomodulatory properties, and they also seem to participate in niche formation. The niches being these specialized microenvironments in tissues where the endogenous stem cells reside. And there's accumulating literature showing the therapeutic potential of mesenchymal stem cells, including their capacity to engraft and undergo trilineage differentiation, albeit in small numbers. They secrete numerous numbers of growth factors, cytokines, immunomodulatory factors, also factors that promote neovascularization, and also have anti-fibrotic effects. And there's evidence that the mesenchymal stem cells engraft and do have cell-to-cell interactions with the host cells. And I'll show you some of that data. So at our institute, we were undergoing a translational sort of pipeline, translational implementation of cardiac cell therapy, where we start in the laboratory, basically isolating, characterizing, studying the mechanisms of mesenchymal stem cells in the lab. We then test whether these stem cells are able to engraft, differentiate, and promote benefit in small and large animal models. The large animal models that we use are the pigs. They're either the Yorkshire or Göttingen mini pigs. And we do a model of chronic ischemic cardiomyopathy that I'll describe in a minute. And the findings, the cell therapy is tested in the animals. Once we establish safety and some efficacy, we then take those findings and translate it into humans and through clinical trials. So the manufacturing process, at our facility, we manufacture the mesenchymal stem cells from rodents, from pigs, as well as for humans. And basically, it's a bone marrow aspirate. The MSCs are isolated. They're expanded in the laboratory. For use in humans, obviously, they undergo multiple levels of testing, including sterility. They have to be endotoxin negative, mycoplasma negative. We test for viability, cell concentration, and the purity of the mesenchymal stem cells by FACS analysis. We check that they are CD45 negative, CD105 positive, et cetera. So there's, as we've been discussing, there's distinct clinical targets that could be looked at. There is prevention of remodeling, and there is reversal of remodeling. So the studies done in acute myocardial infarction are focusing on prevention of scar formation. Our studies, the ones that I'll be talking to you about today, focus on reversal of remodeling. So these are patients who've had a heart attack, who already have a well-healed scar, and what we're trying to do is try to reduce the size of the scar, regenerate tissue, and improve a function. So basically, reversal of remodeling. Obviously, the issues are very different from acute MI to a chronic scar. It's a very different milieu. The delivery of the cells also differs. as I'll be talking to you, in the chronic ischemic model, we do intramyocardial or transendocardial injections of stem cells, whereas in the acute MI models, others have done intravenous or intracoronary. The issues once you have a scar is basically you have to reduce the scar burden, and this would require myocyte growth, neovascularization, so true regeneration. And obviously this has a huge impact on public health, as 80% of heart failure is due to ischemic heart disease. So the model that we use in the large animals is we induce LV dysfunction and remodeling through ischemia reperfusion of the left anterior descending coronary artery, transient occlusion, and reperfusion. And here, I don't have these movies with me, but basically these are cardiac MRIs at baseline, 7 to 10 days, 30 days, 90 days, and basically just showing thinning of the myocardial wall after infarction. You can see that there is reduction in end diastolic volume and systolic volume, increase in end diastolic volume and systolic volume through time as the chambers are enlarged from the myocardial infarction, the scar formation, and there's decrease in stroke volume and decrease in ejection fraction over time. So that's our model. And we usually wait 3 months for the scar to form and then do the cell therapy. So this is the basic design. We do the myocardial infarction. We use female pigs. 3 months after the MI, we then inject either the mesenchymal stem cells or placebo, and the cells that we use are of male origin. So we inject male cells into female swine, so they're allogeneic MSCs, and the reason we choose male is so then we can track with the Y chromosome to try and find the cells and look for differentiation. These animals are followed by serial cardiac MRI, as Dr. Recchia was describing. And at the time of sacrifice, obviously, we take the heart and we do immunohistochemistry studies. So this was data from a few years ago, basically showing in this model, 3 months after MI, you have a fairly large scar, thinning of the ventricular wall, and 3 months after injection, this is your placebo animal. In the MSC-treated animals, you see reduction of the scar and also thickening of the ventricular wall. Again, this is 3 months after injection, 6 months after MI. So with cardiac MRI, we are able to measure infarct size, either as percent of LV mass or as circumferential extent of MI, percent of LV. And again, we see that there's a reduction, significant reduction in infarct size in the MSC-treated animals, not in placebo. We, again, through tracking the Y chromosome, staining for the Y chromosome, we were able to find Y chromosome positive myocytes. These are stained for tropomyosin. We were also found Y chromosome positive cells that stained for smooth muscle 22, a marker of smooth muscle, and cells that were positive for von Willebrand factor, so endothelial cells. We were also able to find positive Y chromosome cells. And again, this is alpha-sarcomeric actin and Y chromosome. So there was evidence that the MSCs were able to differentiate into cardiomyocyte, endothelial, and smooth muscle cells. But the number that differentiate is quite small. Henry Quevedo, who did these studies, actually quantified the number of Y chromosome positive cells that differentiated. And the majority of the cells remained in an immature state. A small percentage differentiated, or at least had markers of cardiomyocyte differentiation, endothelial and vascular smooth muscle. So a minority of the cells shows differentiation, but we were able to find them and quantify them. And we were also able to correlate improvement in myocardial contractility. It correlates correlated well with cell engraftment, and myocardial blood flow also correlated with cell engraftment, suggesting that engraftment and potentially differentiation does contribute to the improvement in function that we see. However, it was obvious to us that the capacity for cardiac repair of the cells exceeded their capacity for differentiation, at least what we are able to find. And so in this study, we again used female pigs, did experimental MI. 3 days later, they received either transendocardial injections of allogenic MSCs versus MSC conditioned media versus placebo. And here we were just trying to find other mechanisms of potential repair. Here again is a cardiac MRI showing 2 days post-MI, the infarct. And in the next panel, you see a reduction in the infarct size. So there was a significant reduction in the MSC-treated animals, and this is 8 weeks after injection. In the conditioned media-treated animals, the infarct size did not significantly reduce. In addition to a decrease in infarct size, we were also able to see that whereas after MI, ejection fraction dropped in all animals, in the MSC-treated animals, ejection fraction recovered over the following 8 weeks, whereas in the animals treated with conditioned media, ejection fraction remained depressed. Again, we were able to find that MSCs engraft, and here again is Y chromosome staining myocytes as well as endothelial cells. But what was most interesting in this study is that the MSC-treated animals had an increased number of c-KIT positive cardiac stem cells in the heart. So it seemed that the mesenchymal stem cells caused proliferation of the endogenous cardiac c-KIT cells in the heart. And you see the cells stained in red are the c-KIT positive cardiac stem cells. And here we see a picture of this is a GFP labeled mesenchymal stem cell in contact with a c-KIT positive cardiac stem cell, and this is connexin 43 gap junction that we stained for. Studies in vitro also showed that the MSCs not only stimulated proliferation of the cardiac stem cells, but also promoted their cardiac lineage differentiation as assessed by markers NK 2.5 and NK4. In addition, we found that the MSCs seem to stimulate endogenous cardiomyocyte cell signaling. So when the animals were sacrificed 2 weeks after injection, we could see that by staining for phosphohistone 3 to look at mitosis, at proliferation, we found that there was a significant increase in cardiomyocyte proliferation 2 weeks after stem cell therapy in the ischemic zone and in the border zone. So these are the conditioned media-treated animals, no significant increase in cardiomyocyte cycling, but in those animals that received MSCs, both in the ischemic and border zones, there was significant increase in cardiomyocyte cycling. After 8 weeks, these numbers went down to normal values. So through these studies in animals, we were able to show that allogeneic bone marrow-derived mesenchymal stem cells were safe, effective as a cell-based therapeutic strategy in an animal model of ischemic cardiomyopathy. And from these studies, we were able to initiate, obtain FDA approval and initiate clinical trials that I'll discuss in a few minutes. More recently, we have been looking at combination therapy based on the results that mesenchymal stem cells seem to stimulate endogenous cardiac stem cells and stimulate their differentiation. We hypothesized that perhaps combining mesenchymal stem cells and cardiac stem cells could produce a greater scar reduction and improve cardiac function in ischemic cardiomyopathy. And again, in these studies, also in pigs, these are MRI images of myocardial infarction and combination therapy. So we did the myocardial infarction, and 2 weeks later, we injected either MSCs and cardiac stem cells, or cardiac stem cells alone, or MSCs alone, or placebo. And then we followed the animals for 4 weeks. And what we found was that there was a decrease in scar size in all of the stem cell treated groups, but the group that received both mesenchymal stem cells and CK-positive cardiac stem cells had a greater reduction in scar size compared to those that received only mesenchymal stem cells or only cardiac stem cells. In these animals, we also looked for mitotically dividing cardiomyocytes, and again, in the infarct zone and in the border zone, and we found that there were increased cardiomyocyte proliferation in all of the stem cell treated groups, but particularly in the combination group. There was a 20-fold increase in cardiomyocyte proliferation in the combination group compared to the other groups. And in the borders, this is in the infarct zone. In the border zone, over 40-fold increase in cardiomyocyte proliferation compared to the other groups. And here again, the staining with phosphohistone 3, and here we see a cardiomyocyte undergoing cytokinesis and karyokinesis. So there's different mechanisms, obviously, involved in the therapeutic effects of the mesenchymal stem cells. There's trilineage differentiation, which promotes regeneration of myocardial tissue and potentially strengthening of the myocardial scar. And we also have a large paracrine effect from all of the different growth factors that are released. They potentially protect from hypoxia-induced apoptosis. They improve homing of exogenous stem cells, improve migration of endogenous stem cells to promote neovascularization. And all of these effects basically lead to improved myocardial function and improved ventricular geometry. There's increasing evidence that the mesenchymal stem cells are also participating in the restitution of the endogenous stem cell niches. And this is from the data that we found that the MSCs and the cardiac stem cells seem to interact. So 3 phenotypic phenomena are occurring in concert. You have improved blood flow due to the neovascularization, improved regional contraction, decreased scar size. And the net increase in ejection fraction is small, but it is present. And the decrease in overall chamber size is also significant. But these findings are actually detected later. And these are the insights that have provided the guidance for us to start clinical trials. I just want to point out that the allogeneic mesenchymal stem cells are a good potential therapy because they're immunoprivileged. So it could be a very good off-the-shelf kind of cell product. They're healthy donors. They can be expanded, they can be frozen, kept in the laboratory, and then used at the time that they're necessary for the patients. And because they're immunoprivileged, the patients don't need any type of immunosuppression. The mesenchymal stem cells are immunoprivileged because they don't express MHC class 2, and they don't express the B7, CD4 co-stimulatory molecules, and they also have inhibitory effects on both adaptive and innate immunity. And as I'll discuss briefly next, the clinical trials that we have ongoing at this time are actually comparing allogeneic MSCs to autologous MSCs to establish their safety and their efficacy. This slide is basically from the clinicaltrials.org, just showing the number of trials. This is as of January, the number of trials worldwide with stem cell therapy for heart failure patients. And it also shows most of the trials have been using bone marrow cells, whole bone marrow. A lot of trials now using mesenchymal stem cells, and as Dr. Anversa discussed, there's trials with cardiac stem cells as well ongoing. And there's different delivery routes: intracoronary, intramyocardial, intravenous. So the translational pipeline, we have 3 clinical trials ongoing for ischemic cardiomyopathy, and 1 ongoing for non-ischemic cardiomyopathy, and another one in the planning phases. This is the Prometheus trial. This trial is no longer open for recruitment, but we have not presented the results yet. These patients were patients with ejection fraction between 20 and 50%, prior MI, as evidenced by an akinetic or dyskinetic segment, and these were patients who were undergoing surgery, CABG, a coronary artery bypass surgery. So they were randomized, bone marrow aspiration was done, mesenchymal stem cells were expanded, and at the time of surgery, the patients then had been randomized to either placebo, low-dose mesenchymal stem cells, or high-dose mesenchymal stem cells. And these patients are all followed serially with cardiac MRIs and echoes. And as Dr. Recchia discussed, the cardiac MRI is very useful not only for function and chamber size, but also to assess perfusion, to assess through delayed enhancement the infarct size, and also for tagging and for the infarct map. We are able to do the tagging and make a map so the surgeons know exactly where they're going to inject the stem cells, either surgically, as in this trial, or transendocardially, as I'll show you in the next trials. So the other trial that we have ongoing is the transendocardial autologous cells. These are human mesenchymal stem cells or human bone marrow cells in ischemic heart failure trial. This was the first trial using the transendocardial catheter to inject the stem cells. And again, this is patients with EF, ejection fraction between 20 and 50%, prior MI, evidenced by an akinetic or dyskinetic segment. Patients undergo bone marrow aspiration, expansion of the bone marrow cells or the mesenchymal stem cells, and these patients were, again, randomized to receive either placebo, mesenchymal stem cells, or autologous whole bone marrow. And they are followed by either MRI and echo. This is the delivery system, the BioCardia helical infusion system, and this system can be used both in the operating room, intramyocardial, or by a transendocardial approach in the cath lab. So we have actually published the results of the first 8 patients that received cells. These patients were still blinded, so we don't know which received whole bone marrow versus MSCs. And this was a 2x2 design. The patients received either the whole bone marrow or the MSCs, either at half or full dose. They were all followed for 6 months using cardiac MRI. And the initial results revealed, again, improvement in end-systolic and diastolic volume and systolic volume, as well as Eulerian circumferential strain, which is a measure of regional contractility assessed by MRI. And down here we have some cardiac MRI images basically showing this is baseline, and after 6 months after stem cell injection, you see a thickening of the left ventricular wall in this particular patient. We also measured infarct size. Again, this is a representative image of one of the patients. This is pre-injection infarct and post-injection, 6 months. And there was a significant decrease in the MI size. The other ongoing trial that we have is the percutaneous stem cell injection delivery effects on neomyogenesis pilot study, we call the POSEIDON-Pilot study. And this study is, again, patients with chronic ischemic cardiomyopathy. And in these patients, we are comparing autologous mesenchymal stem cells to allogeneic mesenchymal stem cells, looking again for safety and efficacy. These results are not out yet, but we are actually analyzing the data as we speak, and we may be presenting it at the American Heart Association later this year. We have a similar study comparing autologous and allogeneic MSCs, but in patients with non-ischemic dilated cardiomyopathy. That's also ongoing. And based on our studies of the combination therapy of cardiac stem cells and MSCs, we are in the planning phases of a trial, also in non-ischemic cardiomyopathy, what we call the AIRMIT trial, autologous cardioblast for reverse remodeling in idiopathic dilated cardiomyopathy. And these patients, this is in the planning phases, but the plan is that they would receive either autologous mesenchymal stem cells or a combination of autologous mesenchymal stem cells and c-KIT positive cardiac stem cells. So our approach has been that we take our basic science observations from the laboratory, formulate a mechanistic hypotheses that we can test in small animals and in large animal models, and then based on those results, formulate therapeutic hypotheses that we then take to the clinical trials. The results of the clinical trials then lead to further mechanistic questions that we can then take back to the laboratory and investigate. So in summary, mesenchymal stem cells are a key cellular constituent of bone marrow, as well as other tissues with cardiac therapeutic potential. Preclinical studies in porcine models have provided mechanistic insights. We have the ongoing clinical trials testing the transendocardial intramyocardial catheter delivery systems, looking at MRI endpoints. And MSCs provisionally have been shown not only in animal models, but also in our human TACHEFT trial, have been shown to reduce infarct size, restore regional function in these patients with chronic ischemic cardiomyopathy. And the ongoing trials that we have are now testing the hypotheses that allogeneic MSCs are at least as effective, if not more, than autologous. And we hope to expand our trials looking at combination therapy. And this is all the people, this is Dr. Hare and all the people in the laboratory that have been doing all these studies. And this is the clinical trial group involved with the clinical trial studies. Thank you.